Okay. Good evening, everybody. Welcome to the Journal Club of this month. I also welcome Dr. Sandilya. I was a surgeon working mainly in the UK. Welcome, Venkat. Thank you for your attendance. It's a difficult topic, I think, and there are lots of learning aspects in this journal club. So, without much ado, I'll ask einass to take over and start the presentation.
Yes, sir. Good evening, everyone. Start, for today's journal club, we'll be discussing the article on development and external validation of prediction risk scores, so as to predict an immediate surgical need in adhesive small bowel obstruction. This was published in the British Journal of Surgery in the month of January in 2025. Uh, the the study design was a prospective observational study which was published in BJS, which has an impact factor of around 8.8, an SJR score of 2.108, and a site score of 7.7. To begin with, a small bowel obstruction is a leading cause of emergency surgical admissions, and 60% of the small bowel obstruction cases are due to post-operative adhesions. The key challenge here is early identification of patients that require surgery versus those that are suitable for non-operative management. A delay in surgery of more than 72 hours increases the 30-day mortality of more than 7%, increases the hospital length of stay, healthcare costs as well, which is a sevenfold increase when the non-operative management fails. Apart from that, there are various prediction models that do exist, but they have methodological limitations such as small sample size, lack of external validation, and retrospective design pattern. The study objective of this our study was development of a prediction model for strangulation, that is the stress score, and to develop a prediction model for non-operative treatment failure, that was the NOFA score. Furthermore, this aimed at providing external validation for both the models. To begin with, what is the research question and how relevant is the study? Uh, in
Satya.
Yes, sir. In terms of the study, it is the small bowel obstruction is quite a common, one of the most common emergency surgical problems that we deal with, and like to decide whether we should consider conservative management or to or patients who require surgery is difficult. And again, as it was highlighted, the delay in surgery always increases the risk of bowel ischemia, and also further adds to morbidity, mortality. And there are certain current guidelines like the Bologna guidelines which acknowledge this uncertainty, and therefore we require validation tools, and there is a lack of these tools that are available. So it is a relevant study to be conducted. Going ahead with the methodology, so this was a prospective observational multicentric study, and the study setting was that in three Finnish hospitals, that was two university hospitals and one community hospital, which included Melihati and Jorvi Hospital, and the community hospital was the Haivinka Hospital. The time duration of the study included study period from June 2014 to March 2023 in the Melihati Hospital, and the other two hospitals had a duration of study between January 2018 to March 2023, and the trial was registered as highlighted. Uh, the study design strategy was such that they had two groups. One was the development group, and the other one was the validation group. So the patients that were present in Melihati Hospital, those patients were used to create the development model, And to test the model, the patients of the Jolvi and Hyvinka hospitals were used. So, in total of 355 and 126 patients were analyzed respectively in each of these in these hospitals, as mentioned. In the outcomes that were analyzed, the primary outcomes were that of to look for strangulation, the operative finding of intestinal ischemia or bowel necrosis or reversible ischemia, and non-operative treatment failure, that is need for surgery within 30 days after initial non-operative management. Methodology herein, the sample size planning was a minimum of 10 events per predictor variable. So, and apart from this, so what they tried to do was at least 10 patients with the outcome of strangulation for each predictor variable in the model were attempted. So, what this means is that they wanted to use 6 variables in these prediction model. These included both the variables like CT findings and laboratory findings. And for each variable, they needed at least 10 patients who had this strangulation. So, 6 into 10 events, that is basically 60 strangulation cases. A minimum requirement of 60 strangulation cases was needed. And here, 50 strangulation cases were seen in the developmental group. The other part was to see for the missing data. So, what the authors here assumed was that there will be some missing, there will be the data which will be sometimes incompletely recorded because a lot of CT findings and investigation parameters were assessed. So instead of not considering or taking these patients into account with incomplete records, they filled these gaps using a method called multiple imputation, that is the mice package in R. So this is basically a statistical way to create complete data sets by predicting the missing values based on the available data. And this is how they try to overcome the chance of missing out the data. The inclusion criteria was that of adults more than 18 years of age, CT confirming adhesive small bowel obstruction, clinically relevant blood samples if they were available. Exclusion criteria was recent abdominal surgery in less than 30 days, inflammatory, uh, inflammatory bowel disease, intraluminal obstruction, and abdominal wall hernia, and even peritoneal carcinomatosis. To begin with the critique of methodology.
Okay, let's um, start with Samir. Samir, are you there? Likit, are you there? Hello? Hello, Likit, are you there? Why is he not answering? Is Likit there or not?
Is there, sir? I think some network issue. He's there, sir. He joined the class.
Likit, can you hear me? I don't know. He's probably always he gets, he's in a spot where there is no good network coverage. Okay, Samir, start with the critique.
Sir, first of all, it is a relevant study, sir. Topic is very relevant, and it is a multi-center study, so it will have external applicability will be more, sir. And they have used external validation for these models, which is a good thing, sir.
Carry on.
Yes, sir. And sample size is also good, sir. 480. Good sample size.
Okay,
Yes.
what else? Okay, let's move on to Nikita and then Praveen.
Sir, pros would be whatever Samir had told, and cons from my side, I was thinking, sir, while reading, whatever the decisions are supposed to be made are done by the operating surgeon or
Hmm.
the consulting surgeon. but they did not define who is the operating surgeon or is there any inclusion criteria for them, sir?
The experience
It
or
is
something.
assumed, sir?
Experience of the surgeon. Is that what you're saying?
Yes, sir. Yes, sir. Because that makes a lot of difference in the choice
But they
which
are
they make.
I think they're all standard protocols which they are using. So I think that probably is less likely to be influential. They have standard protocols for small bowel obstruction which they have actually said. So I think that is very standard. Whichever surgeon is there, probably follows that protocol. Okay.
And the other
Um,
thing
And
was,
Niranjan sir and Ramakrishna sir have joined, sir.
yeah. Good evening, Niranjan. Good evening, Dr. Ramakrishna. Thank you.
sir,
So,
Good evening, sir. Sorry for joining late.
no
I
problem.
had problems with my phone and internet.
No problem, sir. Praveen, critique the method.
Praveen is on call, sir. He's not joined, I think.
sir,
Okay.
if I may, sir, one more point I was thinking, sir.
Yeah.
Sir, the imputation, sir, the
Ah.
overall concept of imputation, is
Ah.
it good? Is it a pro to a study or a con to a study? Whatever the missing data to replicate it or generate it.
See, I think Ramakrishna will also be able to highlight, but see, the thing is, what they have already told in the end of the study is that the data missing were not much. So, one of the methods of overcoming a problem when there is data loss is imputation, and what they have used is a standard thing called the MICE, which is multiple imputation by chained equation. So, MICE R protocol they have used. So, what they have done is to try and minimize the effect or the effect of this missing data on the overall picture. But however, if there is significant loss of data, then obviously it is a negative point. Niranjan first and Ramakrishna.
Sir, it is a prospective study, no? Oh, sorry.
ಹೇಳಿ I have not gone through the paper much. I will not be able to comment ಅದಕ್ಕೆ.
Okay, right.
Same as here, sir. I just gone through half of it. See, this is a prospective study. When you have a prospective study, you should have a protocol, and if you stick on to the protocol, you should not have any missing data. Why that problem of missing data comes when it is a prospective study?
Correct. But the thing is, what they have said in the end is that the missing data was less, but they didn't want to have any missing data, so they have used the imputation using the MICE R protocol.
Sir.
So,
If
but I
missing
think
data
your
are
point
too
is
many,
correct.
then it is a flaw only.
So
another
Nikita,
doubt I had, I don't know whether she has covered. They have mentioned it as a prospective trial, observational trial. I think these two are self-contradictory words. Trial means it is an interventional study. Observational study means there is no intervention. How these two words come together?
Correct.
And they even registered in the clinical trials, sir.
Yes, this is not a trial at all.
There is no intervention. Correct.
But can we assume it as a trial of a model, sir? So utilization of the model.
No, trial means you should have some intervention in the patient. If you institute this data and decide whether he has to undergo surgery or because the score is less, we are managing non-operatively. So if that way you are classifying the patients and giving treatment, then it is a trial. Here they are not intervening anything in the system. They are just collecting the data, analyzing it, and trying to form a this validating scoring system. So this we can't call it as a trial.
Yes.
Yeah. Subbu?
Yeah, can I add something in this?
Yeah.
This is the mainly what I understood in this is it is not only just a observational data, but it is an external validated, meaning those who are the other two hospitals. They have just validated whatever the university, the first university hospital has done it.
Correct.
They have validated it. That shows a bit better accuracy. That's what
Correct.
I understood.
Yeah, I
Yes.
agree. But it's just that it is not a trial. Andre, there is no
Ah,
intervention. There is no
there is no
intervention.
intervention in this. It is just
Yeah.
an observation.
Observation. Yeah.
Yeah.
Observational study. Yes. Anything to add, Nitya and Tanya?
Nothing, sir.
Sir, coming to the pros, as we usually go methodically, like it is a good prospective study, like how we had, I mean, published in a good journal, British Journal
Yeah.
of Surgery,
Surgery.
all
Correct.
those things, and also the tripod reporting guidelines, all those things have been used. The methodology is well laid out with good inclusion and exclusion criteria. So
Yeah.
these are the basic things I wanted to highlight.
Yeah. Correct. I think some of these Samir missed out. Um, so because you brought it out, what is tripod? What is tripod thing?
Sir, it is basically it ensures the transparency, like methodical way of reporting.
So it's a guideline, sir, basically
Like our consort
transparent.
guidelines,
Yes,
Like
Yeah.
exactly.
not like guidelines. It's a guideline.
Wherein you are having a transparent reporting, especially when you are using a prediction model for
Yeah.
evaluation of a diagnosis, sir.
Correct. It is explainability and transparency will be improved by the tripod guidelines, which they have followed. Okay. So, what's your critique apart from whatever has been said?
All of the pros were covered, sir.
Uh,
In terms of cons, like not setting a sample size in the beginning of the study is what I felt was a con because they have
no, it is
this.
not a con because I have explained. See, they wanted to get 50 strangulation cases, so they won't know.
Sir,
So that is why they said we will include the study till we get the set number of strangulation cases. So I think that is not a con because they have defined why they wanted to do that
So, but they
because
did achieve,
uh,
like, if they calculated that way, like, that's what they said, that they had a set of six variables that they decided on, and they wanted like 10 events of strangulation. If that
correct.
was the case, they required 60 cases of, like, minimum of 60 cases, which they weren't able to achieve before
Yeah.
publishing this study.
Uh,
Like around 49 to 50 is what they have achieved. If
yeah.
you go to then that is what is giving a wider confidence interval, like, furthermore. So if there was a set sample size beforehand only, so then would that have helped better in comparison to the model that they used, sir? Is my
It's just that I think they based on the study on the identification of strangulation, whether it is at the beginning or at the when non-operative treatment failed. So I think when they said that as a is one endpoint, then you cannot say how many patients you need to look for till you get those 50 cases. So it's very difficult to set a sample size.
okay.
Ramakrishna sir?
Sir, sir, in this study, actually, sample size should not matter.
Correct.
Sample sizes are important to calculate the power of the study.
Mm.
And for a study, like whether it is statistically significant or not, and if you predict something in conclusion, how strong is that conclusion? Is it reliable or not? To say that, we calculate power of the study. For that purpose, sample size is important. In this, actually, this is not a trial at all. So
Yeah.
here sample size is immaterial.
Not
He
so,
should
not,
not
yeah.
have even attempted that.
Yeah.
The another problem here is they have mentioned primary outcomes. There is nothing like primary outcomes. Primary is always one. Secondary
Yeah.
can be multiple, two,
Yeah.
three, something like
Yeah.
that. But
Yeah.
primary should be single one. They
Single
have
one.
set both as primary outcomes. It's
Mm.
a wrong terminology actually. That he should not have used that. And this primary outcome is important to calculate the sample size. They have not followed any standard sample size here. Just their aim is to collect so many strangulation cases,
Cases,
so that
yeah.
they can, with that data, they can form a scoring system.
Yeah,
That is
very
the
good.
idea. So here sample size calculation is meaningless.
Yeah. Understood, Ainas?
Yes, sir. Yes, sir.
Okay.
So apart from that, exclusion of patients with history of surgery within 30 days. If their point is to look at adhesive small bowel obstruction, then why to exclude these patients?
Correct. It can happen, but
Uh,
the only thing is, because adhesive obstruction may not be the only thing in the first 30 days. It could be sepsis, it could be collection, it could be something else. And, and there can be multiple things. So they thought maybe it will skew the data. So that is why they may not have included. For the first 30 days, assessment of a post-operative abdomen in the first 30 days also is very difficult, because they are now trying to predict the need for intervention in patients with adhesive obstruction. In the first few days, as you know, it is very difficult to assess an abdomen in the immediate post-operative period. So which is why they might have excluded it.
yes. And
What
sir,
I
Moreover, most of the cases of early period, they are flimsy adhesions, and great majority of them they resolve with conservative management.
Yeah.
None of them go into strangulation.
yeah,
So
most
probably
of,
this scoring is not applicable to that particular group of patients, so they have excluded.
most of them are fibrinous adhesions.
Yeah.
I don't think they are total fibrous adhesions. So probably they might have excluded that. That could be one of the reasons.
Yeah. Right. I think that, okay.
yes, sir.
Go on, Ines.
And uh, going ahead to the statistical analysis, so they had variable selection strategy and model development. So to tell in simple words, from 355 patients in the development group, they recorded the clinical signs, that was abdominal guarding, lab tests like neutrophil to leukocyte ratio, and CT findings like the closed loop sign of leaf fluid levels, and patient's history, that is the number of previous small bowel obstruction episodes before this. And they didn't just pick up these variables randomly, is what they have said. They combined this in comparison to previous literature research, like expert clinical consensus, and the clinical utility of all of this, and univariable analysis. After going through all of these approaches, they chose these few findings, like the variables that they came to. And after that, they built a formula using binary logistic regression. Uh, that is a standard statistical method, which is that relates predictors to the chance of the event occurring. In this case, strangulation or failure of non-operative management. And because of this, they have developed two scores, that is the stress score and the NOFA score. And after this, the performance metric they calculated using the ROC curve, that the area under the curve score. And they also looked at calibrations, whether the predicted probabilities match the real outcome. So this was how they developed the model. And to validate this, they had two methods. One was internal validation. This they did by bootstrapping and bootstrap resampling. So repeatedly, that is nearly 1000 times, they took random samples with replacements from the original 355 patients, and they rebuilt the model each time and compared the performance. And this would show how much the model might overfit or give unrealistic values. And the external validation was done to a separate group of 126 patients. That was the other two hospitals that they used. And they again measured discrimination, that was by area under the curve, and calibration. So that calibration basically meaning that the predicted risk, that did the predicted risk actually match the actual risk. And and that is how they validated both the models.
Great,
uh,
great.
yes, sir.
Samir,
Yes, sir.
What do you understand by bootstrap resampling?
Sir, for bootstrap, it is like for the internal validation, we'll draw a data set for the same size, and then we'll feed the prediction model. So, like multiple times, we'll keep on feeding with different data sets, sir. And then we'll calculate the difference.
Not different data set, same data set.
I mean,
You
yes,
do
sir. So from the
simulated multiple sampling.
multiple sample, and then we'll calculate the difference from apparent from the test, and then that will give us the optimized correction, sir.
So, Dr. Ramakrishna asks Nikita,
Yes,
what is internal and external validation?
sir. Internal validation within the same data set, whatever the causal relationship we have created or we have hypothesized, to see in the same data set is internal validation, sir. But if the same hypothesis, if you want to apply elsewhere and like to check elsewhere, that would be external validation. So it is confirming that whatever we have made a causation is right or wrong. It's more validating, sir. External validation.
Okay, can you add to what Samir said about bootstrap resampling?
Yes, sir. By an example, I will can I tell, sir?
Yeah, of course.
Yes. So if we have told that people who watch movies are happy, and we are trying to revalidate the same concept or hypothesis, so we are randomly taking the whole set of the people whom we have studied and applying the same logic to them, saying that is it really right or is it really right? So all the samples, if you are keeping it again in the same model, but we are able to reproduce the same result, then it is more validated. So bootstrapping is nothing but taking the same data and putting into the letting it go through the same study pattern, whatever has happened, sir.
You mean to say it is simulated sampling? Created
Yes, sir.
simulated
Simulated sample
sampling.
with same data set.
Same data. Okay. Nitya, anything you want to add?
Mhm. No, sir. Like what she said is what I was thinking. Like that is the thing, sir.
So, what is the need to do a bootstrapping?
To
Sample.
improve the validation, it becomes
Recheck.
better, sir. Like it's getting again kind of uh, correct. Like it is just re-emphasizing the validation, sir. That's what I.
I think the three important things of bootstrapping is to calculate standard errors,
Yes.
to construct the confidence interval, and also to perform hypothesis testing. So these are the three principles on which bootstrapping is done. So you simulate the same, create simulated samples using the same data set, so that you create this, so that you validate your data. So that is the thing.
Sir asked what is optimism, sir.
Ah,
So
what is optimism correction?
in bootstrap resampling procedure, most of the time we try to predict what we want to predict, sir. So to minimize that, they do this optimism correction. It's to reduce the bias of this bootstrap resampling.
Okay, correct.
Uh,
And
what
what
I,
is
sorry, what I understood
yes, Subbu.
optimism is to reduce the underestimate or overestimate the likelihood of positive outcomes.
Correct. I think, yeah.
That is what I understood. Probably that is the one. I don't know.
Yeah, correct. And what is shrinkage factor calculation, Nitya?
Mm. I'm not really sure, sir.
Einass, what is shrinkage factor calculation?
So, in conditions when there are like when you are looking at many variables and you have a small sample size, and you can like the so as to correct the coefficients, there may be overfitting. So shrinkage is basically a method which you are using to like basically reduce the regression coefficient, sir, so that the model will be performing better, sir. uh, and then basically it is scaling down the like regression coefficient is what it
Yeah.
means. And the interpretation is between, like, you get values between 0 to 1, and 1, if the value is closer to 1, that means that there is less overfitting. And if the value is much lower than 1, closer to 0, that is when there's more overfitting.
Overfitting.
So
Yeah.
chances of bias is more, and that is when you should try to reduce the regression coefficient should be reduced more, sir. uh,
Correct. So I think both of them, optimism correction and shrinkage factor calculation, are kind of similar to reduce either overcorrection or undercorrection.
yes, sir.
Ramakrishna sir, anything to add?
Nothing, sir. Basically, bootstrapping means whatever resources available using the same thing. That's what bootstrapping basically means. Here, they already have data of some 300 something patients. So they are using the same data to say, see whether the prediction out of their scoring system works or not. So in other way, it is internal validation. This shrinkage is to reduce the sampling variation. If there are a lot of variation in the sampling, like one patient has got strangulation, another did not have, that means lot of variation is there. It is very difficult to analyze the data. So what they do, they try to reduce this variation by some statistical methods. So that is called shrinkage.
Yeah. Okay, carry on.
Yes. So the scores were that of Strisk and NOFA score. This was the Strisk score with the features that were mentioned, which included abdominal guarding, neutrophil to lymphocyte ratio, small bowel feces sign, and CT findings of closed loop obstruction, and the total score with an estimated risk of bowel strangulation as shown. This was the NOFA
Go
score.
back, go back.
Yes, sir.
Okay, Sania, what do you understand by all these things? Abdominal guarding is, is self-explanatory.
Yes, sir.
So, do you think all patients who come with obstruction, small bowel adhesive obstruction, the moment there is guarding, you take for surgery, there is risk for strangulation?
So guarding, yes, sir, it could be secondary to peritonitis, which indicates that there is either ischemia or infection or something which is causing all the peritonitis. So guarding, yes, sir.
Guarding.
But
Okay. What about neutrophil to lymphocyte
the
ratio?
neutrophil, no, sir, that one may be patient may be having some other source of infection also, which could lead to this elevated ratio.
No,
So
but
there we'll have to assess, sir.
but they say that neutrophil to lymphocyte ratio is more of a predictor than just taking total leukocyte count.
Yes, sir, yes. Uh,
What about small bowel feces sign?
So again, so small bowel feces sign, we can give a trial of conservative management by giving contrast, which can push out the bowel, stools which are impacted or which could be giving the small bowel feces sign, sir.
No, but what does it
There
indicate to
also.
you? The presence of small bowel feces.
Sir, one, it could be because there is delayed peristalsis, because of which there is stagnation of the this thing, or there could be actual obstruction happening for the distally. That is why there is small bowel feces sign seen, sir.
The presence of small bowel feces, is it good or bad?
Yeah, sir, it is kind of bad only, but based on the
No,
patient's
no.
condition,
It is
I think we
actually
can give a
good.
trial.
The small bowel feces, see, if there is a lot of fluid and there is no, that means the obstruction is real and
Yes,
probably the
sir.
patient needs surgery. The presence of small bowel feces means that you can
It is
probably
infection.
wait and watch. You
Oh,
can
yes.
probably wait and watch. So that is what it means. What about
Yes, sir.
mesenteric edema and free peritoneal fluid?
Again, it could be just inflammatory reaction to some infection happening inside, sir, which could be still managed conservatively.
But
Or
presence
it
of
can
peritoneal fluid, presence
fluid
of
that could be secondary to any strangulation or ischemia of the bowel that has happened, sir.
yeah, that presence of fluid is a bit more of a more
Yes, sir.
serious sign.
Concern. Yes,
What
sir. Yes,
about
sir.
closed loop obstruction?
Closed loop obstruction is a very concerning sign, sir.
Almost
Yeah.
always,
Yes,
because
sir.
very
Almost
rarely
always.
closed loop obstruction relieves on its
Can
own.
on its own. Correct. Yes, sir. But
Anything?
previous episodes of adhesive small bowel obstruction are more towards favor
Yeah,
of managing it conservatively, no, sir?
correct. More number of previous episodes, the less chance of surgery.
Surgery, yes, sir.
So which means if there are no previous episodes, very
Then
high
it could
chance
be
of surgery.
acute rather than subacute.
That is why they say in a virgin abdomen, you don't
Don't
let
wait for
sunset on intestinal small bowel
obstruction.
obstruction.
Yes, sir.
So
Yes.
if there are no previous surgeries, you have to operate. If there
Yes,
are
sir.
surgeries, more number of surgeries, less chance of operating.
Yes, sir.
Anything to add, anybody?
So if any one of these things are present, you can still wait according to this.
Yeah.
So if even if you see closed bowel obstruction on CT, according to this, you can observe if other things are absent.
The previously we were taught like the earliest sign of any strangulation, potential strangulation, is a persistent tachycardia. I don't know now whether it is acceptable or not with all these things. I just don't know now. Nowadays they don't teach that.
No, they have actually not included those general signs. They have only included abdominal signs, laboratory, and CT findings. Maybe that
Yeah.
is something that we can look into. Niranjan, anything to add to this score?
Nothing, sir. Maybe as sir was mentioning, onset of new tachycardia probably will be a alarming sign. Patient who was normal pulse rate, sudden onset of
Yeah,
high pulse rate probably will tilt the favor in favor of going in for strangulation.
that is one thing. And as Subbu said, if a patient is to present with has tachycardia and then despite fluid correction and giving
Yeah.
antibiotics and an
Persistent
observation,
tachycardia or new tachycardia.
persistent tachycardia or new tachycardia, I think they should be definitely alarming signs. Yeah,
Of course, that they have not included
yeah,
anyway.
they are not included. Okay, next, go on, Einass.
Sir, a small doubt, sir.
Yeah,
Because while taking the details, they have considered all these points into account. But once they came to the predictors, like the ones they choose for the score, they have used only these 6 points, sir, separately. So maybe the other factors were not significant enough for the score part.
what do you mean? Which you
Like
mean to say
tachycardia,
that?
sir. Tachycardia was taken into account in the initial whenever they were
Okay,
taking the details.
yeah, maybe, yeah, maybe.
Maybe other low risk, high risk patients and low risk both had the tachycardia. So maybe it's
Maybe correct.
Yes, yes. Like
No,
initially, they have told her that they did like on based on previous analysis and like what they told this as a univariable analysis and expert opinion. Based on that is how they have come to
To these points,
choose these
yes,
6 points.
yeah, okay.
no,
Einass, carry on.
usually the standard technique in multifactorial analysis is you enumerate all the data and see which of them statistically significant. And then they select only those data
Those data
and
points,
they
yes,
ignore other things,
yeah, correct,
assuming that others are not significant.
correct.
That prediction or assumption could be wrong also sometimes
Wrong
because
also,
the
correct,
p-value is not an absolute thing. Many
correct.
times it is statistically significant, but clinically it may be insignificant, or the reverse,
Reverse,
statistically insignificant, but
Clinically significant.
clinically it is significant. So that's how the p-value should be interpreted. And for this scoring system, the authors have considered only
These six. So the study, this one is Subbu's and Niranjan's point is very well taken. A persistent tachycardia and new advent tachycardia should be taken, seriously. Okay, so don't let that. It was not there in the NOFA score. Okay, right. Carry on.
Yes, sir. Into the critique, sir, of
Has Praveen joined or not? Is he not there? Or is he conveniently escaped? Praveen?
He is joined, sir.
Praveen, have you read the article? Hello? He's not answering. Okay, Samir, critique. Golden silence. Samir?
Yes, sir. Yes, sir.
Come on, man.
So both the models, like the stress model and the NOFA model, were they had excellent, the discrimination was very good, sir. Both in internal validation and external validation, both were almost same. So the OR score was same, almost same. So both models were performed well, sir. And they have taken variables which are like we can reproduce them, guarding, closed loop, species line, mesenteric edema, all those things. And uh, there is a risk of stratification, sir. Like they predicted groups on various risks, low, moderate, and high risk, which is also a good.
Okay. Praveen, are you there now? Can you answer? Is he there or not there? Or is his
He left,
connection?
sir. He left.
No, but I'll tell you guys, when you are there in the class, if it is just suturing and something like that, it can wait. So don't, just to escape the class, don't go and do some suturing. If it is anything serious emergency, of course you have to go. But otherwise, please don't go for just because the casualty fellow is telling you, come and do this suturing. Okay, Nikita, your critique.
Sir, so as of now, it is all about the methodology only, sir. The methodology, whatever they laid up, is all well and good with a proper structure and validation, sir. The results are yet to be discussed. The cons I'm not very sure of, sir, because most of the things are new to us. The new concepts are sounding good, but we don't know the negative aspects of those validations and this correction, sir.
Correct. I think that's a very honest admission. I would also second that. Sanya and Nitya, anything to add to the critique?
No, sir. I think they covered it, sir.
Right, einass.
yes, sir. Like the appropriate model selection, like doing the bootstrap method and the calibration assessment, all are pros. Actually, so the cons are it will make much more sense after the results, sir. It was added here, sir, but like events per variable because they mentioned it in brief, but the it actually is highlighted in the results, sir.
Correct.
Yes, sir.
So you think binary logistic regression is a suitable thing for this?
So like ma'am said, sir, that it's new, sir, and based on what the data says, sir, like when you have such a cohort and such a sample size, then this is an ideal test that should be used, is what is suggested in
Yes,
this.
correct, because it is either yes or no thing.
Yes, sir.
So So binary, it is binary, and the logistic regression is the correct thing to have used.
Yes, sir.
Okay.
Uh,
Ramakrishna sir, anything to add? Subbu, anything to add?
No, I think it is, my idea is it's good one, good study, that too with an external validation. Clear external validation is an important thing. Of course, as you said, it may be inadequate external validation because of the size,
Yeah.
maybe.
Ramakrishna?
Yes, sir. I have not gone through full articles. Einass called only at 8
Yeah,
o'clock
yeah.
and I hardly had half an hour. So these things I have not studied completely, sir. But I think the presenter has almost completely done it well.
Yeah. Okay. Carry on.
yes, sir. Going to the results. So, in total, there were 460 patients in Melihati Hospital and 166 in the other hospital. Based on the exclusion criteria, ultimately they came up to 355 patients and 126 patients. Amongst these, out of the 355 patients, 53 patients underwent emergency surgery and 302 had non-operative management. And out of these, 29 had developed strangulation, and in case of failure of non-operative management, again, there were 93, out of which 29 and again developed strangulation. And in the the validation group portions, in the other two hospitals, 18 patients underwent emergency surgery, out of which 13 had strangulation. And in the non-operative failure group, 3 patients had developed strangulation. In terms of assessing the results, in the initial first figure, they have highlighted on the age, and basically they have tried to show that both they've compared the age, the BMI, other comorbidities, any previous abdominal surgery, any history of pelvic surgery, and previous episodes of small bowel obstruction. And what is found that there is in both the development group and validation group, they were comparable. There are similarities that are present. And amongst these, they have highlighted that the immediate surgery was needed at about 15% of patients. Strangulation occurred in 16% of the development group and 13% of the validation group. And apart from that, the P column is developing, showing the statistical test comparing the two groups. And here only the history of previous pelvic surgery, and that is what has showed a statistically significant result. Uh, again, in the second table, again they have shown the predictors and the meaning. So basically, they have calculated odds ratio over here, and higher the ratio, higher the risk is noted over here. Uh, the NL ratio has shown a higher ratio, and so that is how they have assessed the other 6 predictive models. Further ahead, they have used calibration plot curves, so as to uh, like uh, in this, each graph will check the calibration and whether the risk predicted by the model is matching with what really has happened. So what the x-axis is showing is what is expected, and the y-axis is showing what was observed. The x-axis being the risk that was predicted by the model, and y-axis the actual percentage of the patients who had that event. And in this, the black dotted line is the reference line, and the blue line is showing the actual data, and the red dots are showing the groups of patient at different prediction levels. So what we can see is the left graph, where the strangulation line is, the blue line is close to the black line, ultimately meaning that prediction of bowel strangulation is closely matching the real frequency. And the right one is again the non-operative treatment failure group. Is showing again that blue line is close, but it is slightly upward at a higher risk. Means that the model is slightly underestimating the risk of for the patients at the highest prediction level, but overall accuracy is there. This was for the development group, and the lower bottom row is again showing this is showing the validation cohort. Again, in the left group, we can see that the blue line is close to the black line, but a little skewed. So the calibration is good here, and the non-operative failure group again indicates a stable calibration. This is how they have represented the data, and finally, so this is the like failure of non-operative management. Again, here they have applied the odds ratio score to so as to assess an area under the curve, so as to assess the like the accuracy of the NOFA model, and the results are highlighted here, which are significant. Uh, Going to the critique.
See, what baffles me is that go back to the last one slide.
Yes, sir.
Is that the area under the curve seems to be giving an either. See, they say that between 0.6 to 0.8 is excellent, and 0.8 to upwards is outstanding. So that is this one that is closer to 1. So this comes in the range of being excellent. But if you look at the Nagelkerk R prediction model, that again closer to 1 is desirable, and it seems to be hovering around 0.2 to 0.4, so indicating that it is not as good. So how do you make the difference between the area under the curve and the Nagelkerk model? Golden silence.
We did not
Anybody?
actually understand to that extent, sir.
Yeah. I think these are terminologies that have been introduced again in this class. I had never
Yes,
area
sir.
under the curve we know, but Nagelkerk model I have not. I don't know much about. Ramakrishna sir, could you? Is it possible for you to highlight that, sir? Because if you look at the area under the curve, it seems to be a very good prediction model, but the Nagelkerk method indicates that I think the best score is around 0.45 or something. So it is, they say again nearer 1 is better anta. So how do we sort of equate this dichotomy between the two prediction things which they have used, or are they
You
looking at
need
different things?
to study more.
Yes,
Study
sir.
more on this particular topic and find out. But
Yeah,
the observed and expected, it is showing good in the observed cases, but
correct.
in the validation cohort, it is deviating quite significantly, especially this population. This expectation is going somewhere, and this strangulation is going somewhere, but they are telling it is okay.
That's something that I didn't understand. And Niranjan?
The expected is this dotted line.
Yeah,
If this is showing 0.8, that also should show 0.8. So
correct,
that is this dotted line at 45 degree.
correct.
So it should be very near to that, like in the upper this one, strangulation in the observed. So this is going very near to this dotted line. So it is good.
Go back, ma. Go back one more. This one. Yeah,
Yeah, this upper left strangulation
correct.
in the development cohort. So it should look something like this in the validation cohort also.
Validation called out also. Yeah,
Then it is a good prediction or a good scoring system. Probably if some more people or some more centers take up this scoring system, like we used to do this Alvarado score, there's
yeah,
Ripasa. So
correct,
if you study, many studies come up, and if they show there is significant deviation, probably the scoring system will fade away.
correct.
And ultimately, the aim should be to predict till at that particular point whether surgery is required or not.
Not.
It is not telling that. They are just telling high risk, low risk, very high risk, like that. And if you manage according to this, only the first and last group, it is okay. The moderate risk and high risk group, if you say, see this high risk group, they say high risk. And if it is managed non-operatively, 38% of the patients, they recover according to this. I think she's stuck there. Next, what is this? Figure number 3. If you see the figure number 3, 38% of the non-operatively managed patients in high risk group, it succeeds. So what is the prediction in this? And again, if you look at the strangulation, in moderate risk also, some 23% they developed strangulation. So
Right.
this prediction, maybe if you are only studying it is fine, but when a particular patient is in front of you, you do the scoring system and ask you what you will do with this scoring system. According to the scoring system, you should be able to say whether this patient requires surgery or not.
Not.
That is the clinical usefulness, but that is not observed in this particular group.
ಅಲ್ಲ ಅದೇ
This is a
ಬೈನರಿ
major flaw in this.
ರಿಗ್ರೆಷನ್ ಮಾಡೆಲ್ ಅಲ್ಲಿ there is a 70, it comes to somewhere around the excellent range ಅಲ್ಲಿ ಬರುತ್ತೆ, but this other method ಇದೆಯಲ್ಲ, that one I am not, Nagelkerk method, I don't know, the R2, the prediction method, I think it is, it is needed to be a bit more than just 0.4 or something like that.
It is difficult, sir.
Difficult.
They give so many things and ultimately they conclude this is a good scoring system. But the clinical application of this scoring system is questionable.
Okay, Einass, move on.
So the critiques of
Yeah.
the results. I'll
Yeah.
So, like the pros that they have shown is that there's consistent performance, and especially in the NOFA model, which has an area under the curve of 0.75. According to them, both models are showing acceptable calibration slopes, and apart from that, there is clear gradients across low risk to very high risk groups. In terms of cons, the confidence intervals are very high, and especially in the external validation group, going like 0.822 to 0.993, which is showing highlighting uncertainty, and only 16 strangulation cases for external validation makes it unreliable, sir.
Okay, carry on.
For coming to the last part, discussion in this, so what this bar graph basically has illustrated that the outcome of patient in that group, blue being non-operative treatment success, orange being non-operative treatment failure, red is strangulation without bowel resection, and purple being strangulation requiring bowel resection. And the interpretation that was done was vast majority, nearly 85% have recovered with non-operative treatment. Very few had strangulation, with which 0.5% had no resection, and nearly 1.5 had resection in the low risk group. In the moderate risk group, non-operative treatment success was dropped to 68%. And in the high risk group, 38% succeeded with non-operative group. And in the very high risk group, only 19% had non-operative treatment, and nearly half, that is 47%, had strangulation risk requiring bowel resection. And strangulation without resection was seen in 23, and non-operative failure, that is 11%, was noted in the very high risk group. So what they have said is that adhesive small bowel obstruction is a frequent cause of emergency admissions, and they tried to develop and externally validate the stress and NOFA score, and with the 6 variables that were included. And the models have demonstrated good predictive accuracy with area under the curve value of approximately 0.86 for the stress score and 0.75 for the NOFA score, and have had a stable calibration on external validation. And the strength of the study was included the prospective design, a multicentric setting, and external validation, while the limitations were that of a small validation cohort, the missing laboratory data, the imputation that they did, and lack of assessment of a transition zone in closed loop obstructions. These models can aid in early surgical decision making, potentially reducing delay, morbidity, mortality, and healthcare costs. Uh, and although further prospective implementation studies are needed before widespread adoption, there are a few other studies which were conducted, one being again where they had used a prediction model for recognizing strangulation small bowel. Here they had looked into certain CT findings, and they again had used along with that WBC curve and small bowel thickness and ascites. And they had concluded that it is a good model to evaluate severity of SBO. However, they did not attempt to externally validate it. Again, the other two studies were prediction of success of non-operative management and factors associated with the failure of non-operative management. There are not a lot of studies wherein they have attempted to make a score so as to decide which patients will require surgery to prevent strangulation, and furthermore trying to externally validate this study. So furthermore validating their study. These were the
Correct.
only three studies that I
Yeah.
came up.
So I think what Dr. Ramakrishna asks is a very valid question. Once you risk stratified them into low risk, moderate risk, and high risk, once you come to high risk, the thing is, how can you justify, a non-operative management in these people? Because the risk of strangulation is quite high, mortality probably also is quite high. How can you justify it? The purpose of this stratification is to guide you, to make clinical decisions, isn't it?
Yes,
Subbu?
yes.
Hello, Subbu?
Yeah, what I understand is the first two, that is the low risk, moderate risk is okay. But that high risk group, I don't think it is matched properly. Because it's if you can go it's about nearly 38%.
Go back to that figure, ma.
This one, 38% non-operative. That's quite a large number with high risk. 30% is strangulation. I don't think that matches very well. I mean, this particular study.
So, Niranjan, what do you think of this? When you risk stratify, the purpose of risk stratification is to guide you, by the risk. For example, you can understand low risk and moderate risk. High risk and very high risk, how can you justify doing non-operative management?
Yes, sir. I also agree with sir's fine, whatever sir said there. I also cannot.
Isn't it all retrospective, sir? This is the whole population of the study. After creating the model, they're just seeing how many patients have undergone this group thing in a very high risk group.
So then the recommendation has to be that, you can do non-operative management in low risk and moderate risk group, but not in the high risk and very high risk group.
Yeah, that's what I understand.
That's a recommendation. That should be the recommendation. That they should have been more clear about recommending that.
Recommendations, yes. That's one.
No, sir, it is something different. My thinking is little different than this. See, what it predicts is high risk. That means the score should be 4 and 5.
Yeah.
So even if the patient has got score of 4 or 5, if you manage conservatively, that is non-operatively, 38% of them will succeed.
Correct.
This is what this graph predicts.
Correct.
So Based on this, and if patient comes under high risk, how will you decide whether to operate or not to operate?
That is the thing. So the
How
risk
to
right number.
risk prediction scorally. So, but
Yeah.
still, even though 38% of them have succeeded, a significant 62% of them have either gone into strangulation, needing resection, not needing resection, all those things. So, on balance,
See, what
you
I'm
may have
telling
to.
you is to make a clinical decision based on this score, you will be correct only, you will, or I can say you will be wrong 38% of times.
Yeah.
Yeah.
If you say surgery for high risk patient based on this score,
Yeah.
you will be wrong 38% of times. That is
Right.
a huge negative laparotomy.
Negative laparotomy. Yeah.
So you may have to do a diagnostic laparoscopy in that situation.
And that is also intervention, no?
Intervention, but
Mhm.
at least you will avoid a laparotomy.
No, what I am telling is only
Correct.
these extreme groups are okay. Group 1 on that last very high risk. So these two groups are okay because about 19% negative laparotomy, okay, we can accept, but not 40%.
Correct.
So in between, if it is there, you will not be wise with this scoring system also, and you have to take your own decision based on your previous knowledge and experience. That's all.
Correct.
This scoring system will not help in those patients.
Correct. I think it is like Ramakrishna when they did the this breast screening for for malignancy. What finally they found out was that they were picking up interval malignancies which would have actually done well anyway. So you have not picked up the high risk group anyway at all. So interval malignancies which you pick up in the breast screening, they will do well anyway. So the breast screening has actually not helped. But only thing is it has created awareness among women, and it has also created a lot of anxiety among women. Ange, idu I think in the low risk, intermediate, moderate risk, and very high risk, it is okay. But with the high risk group, there is a lot of uncertainty. So
actually, this breast screening, now they say in UK it's a big scam. Because
correct.
As you said, whatever that interval malignancies you have picked up, whether you picked up early or late, it's that outcome is almost the same.
Same, correct.
What is the point in wasting so much of
resources and also making a lot of women very anxious?
That is.
Yeah. So, what is the conclusion, ma? Einass, go to the conclusion.
Sir, like
You're
that
not.
sir, I combined the discussion and conclusion together.
Okay.
Like,
Yeah. Okay. Give the last statement. The discussion. The last. Go back to that slide.
Yes, sir.
So the prospective multicentral external validation limitations, small validation cohort and laboratory data. But the laboratory data missing was not that much apparently, so it's okay. So I don't know whether you can say early surgical decision making and potentially reducing delays. You can make such confident statements. I don't know. So I think, as you said, because there are no prediction models, and this seems to be a reasonably good one. So a multicentral trial with significant external validation may help in deciding once and for all whether this is a good prediction model or not. I think that is the best conclusion we can make. Ramakrishna sir?
This I feel this is not clinically applicable in this present form, sir. So
Correct.
even after doing the scoring, you are not more wise in deciding whether to operate or not to operate. Most of the time, you will be deciding based on your knowledge, experience, and your sixth sense or something like that.
And CT
This, I
findings.
think,
Yeah.
if some PG is ready to write a comment and write it as a letter to editor to the BJS, we have done it twice previously, and both the times we have succeeded. I think if anyone takes up, we can
Yeah,
write
yeah.
a letter. This is a recent article. That is good thing, so
Yeah,
that
yeah.
we can
Correct.
mention
We
on
should
the
write a
class
letter.
and
Yeah.
all. It should be written, sir, because this gives a wrong impression to a reader.
Correct.
Based on this, we have to go, and some of the important things, what we clinically consider, it is ignored, and
Yeah.
some of the things which are there may not be clinically significant
Correct.
in this.
Yeah.
So it is a very difficult thing to apply clinically. Just apply means apply to decide whether to operate or not.
Correct. So, Nikita, will you take it up or anybody else?
Sir, we
Nitya.
we need to validate this in our setup or in our population,
It is
sir.
very difficult.
Difficult?
Very difficult.
No. What I asked was what Dr. Ramakrishna suggested, to write a letter to the editor of the BJS highlighting all the things that we actually discussed. It should be about less than a page, I think. So I think if you
Oh, there
go,
is word number restrictions, sir. Letter to editor, I think some 300 words or something like that.
correct.
I have to check in that website. They have mentioned there is a restriction. Only
Restriction.
that many words. If you send more than that, they will send back.
So will you, Nitya or Nikita, will you take it up and show it to me?
Sir, einass has done the whole journal club,
Okay,
sir.
let einass. Yeah,
We will
einass.
do it together. Yes, sir.
Do it together, show it to me, then we will send it.
Yes, sir. Yes.
Subbu, final comments?
What I think is just an observational study. And in the beginning, they said we have not even taken any consent because there is no intervention involved.
Correct.
So that is one thing. Something like a NELA score, National Laparotomy Score, NELA score, that can be, I mean, one of these, girls can just modify it and make it as a scoring system rather than just a study, rather. Might help. That's what I understand. So that can be quantified, the risk, everything.
So send us if you have the nailer score, if you have it, send it.
NELA
Put
score,
it.
I will.
Yeah, put it in the group, and we'll look
I'll send
into
you.
that. Yeah.
Yeah.
Niranjan, final thoughts.
Sir, nothing to add, sir. I agree with Ramakrishna's comments.
Yeah.
It's difficult to probably put it into practice in our setup.
Yeah. From the registrars and
And
junior
Aina is
consultants.
well done for a difficult topic, and you have prepared well.
Yeah.
A very,
Aina's
a very
well.
tough topic. It's a lot of new things you learn
Yeah.
in this.
So I think even though I only left the choice to to the girls and boys to decide which to present, but because there are a lot of new learning,
Yeah.
points in this, I let it be. Otherwise, there were other studies which were good also. But Ainas, you did extremely well. I think you have understood the topic well. I think probably better than all of us, which is good.
Thank you, sir.
Nitya and Sania, comments?
Sir, exactly like even I wanted to say, Inas did really well, sir. Like she will be having in-depth knowledge, and she would have gained more insights into all these statistics, sir, which we found it very difficult. Maybe in the process of preparing, she would have had a good grip over the statistics also, sir.
All of you go back and read up about the things like the binary regression, then the area under the curve analysis, then the tripod, statement, and mice package in R. All these things, you please go and, I think all of you need to read up about these things. And this, I've not had this Nagelkirk or this one also. I think you need to study about that. I think. Otherwise, good effort by Ainas, and good
Thank you, sir.
paper, which set off a lot of thinking, but ultimately not, probably clinically very relevant for the reasons we have explained. Okay, so if there are no other comments, we'll stop. Good night.
Thank you,
Thank
sir.
you everybody for participating.
Thank you, sir.
Thank you, sir.
Thank you.